All right, well, good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, would like to welcome you all to the second webinar in a three-part series about providing dental care to patients with IDD by Dr. Mark Bullock. Today's topic is entitled Special Conditions, Barriers, and Challenges Providing Dental Care to Patients with IDD. If you missed Dr. Bullock's first presentation on providing dental care under an advanced anesthesia, oral sedation, IV sedation, TIVA, IV MAC, and general anesthesia, you may find the recorded version on our website at texsoc.org under the Education tab and live webinars. Our presenter today is Dr. Mark Bullock, a special needs dentist and dental director at the Abilene State Supported Living Center, a state facility for individuals with intellectual and developmental disabilities. He previously served as the chief dental officer for Mercy Ships, providing free dental care to the people of West Africa. After earning his dental degree from the University of Texas Dental School of San Antonio, he completed a one-year Army residency in advanced general dentistry. Driven by a passion for underserved dental patients, he takes pride in providing comprehensive and compassionate dental care to patients with complex needs and challenges. As a special needs dentist, his goals include improving access to quality dental care for patients with IDD. So it is with extreme pleasure we welcome back Dr. Mark Bullock.
Hello, everybody. I'm going to see if I can get my screen shared properly here. Hello, everybody. Thank you for having me, Ms. Beth, and thank you to the Texas Oral Health Coalition for all you guys are doing for dentistry in Texas. I'm going to get started here. I cut down my slides a little more because I felt like I was rushing a little bit on the last, so I'm hopefully didn't cut it down too much and end early, but I think it's better than pushing the time too much. We have to start with disclaimers, as always. Same as last time, I have no financial interest or conflicts of interest. I don't believe I'm talking about many products or any products today, but if I do happen to say a product name, I don't have any affiliation. I'm not paid by anybody to say that name or anything. Content is my own opinions based on my own experience. I do not speak for the state of Texas, HHSC, or any of the state supported living facilities. If I do mention anything, my facility, it's very much something that we do here. I'm not expecting it to be used as grounds for doing things elsewhere. Especially today, it's mostly just my own past experience. I didn't have a lot to draw for barriers and things. So it's really just kind of some of the things that I was introduced to when I first started working here. It's been about 8 years now. So I really don't have any special needs training or degrees. If you have a better way of doing things or more letters after your name, I'd be love to chat with you, because what I've found is it's kind of school of hard knocks when it comes to special needs. It seems like there's not a lot of centralized, especially here in Texas. I think there is some coming, but definitely when I was doing my training, I've looked for things. There's just not a lot of really solid training applications. So anything I mention here, I'm not trying to make standards of care or guidelines or best practice. I'm definitely not trying to write policy in any way. So please understand that if I say something that's off, that you don't agree with, I'm not in any way trying to tell you how to treat your patients or anybody else. So lastly, if I do mention any board rules here, I'm not an expert in board rules. I know I work for the state of Texas, but I don't work for the dental board. I definitely don't have them all memorized. There's a lot to the Texas Practice Act and the board rules. So please do your own research. If I say something, please go back and try and look that up for yourself. Lastly, time, like I said, I hopefully not going to finish early, but I did cut down my slides hopefully in the interest of finishing quicker. So objectives are pretty simple. I'm really just going to be talking about some of my experiences and hopefully giving you some pearls about how to overcome some of the barriers and challenges I found working with people with intellectual and developmental disabilities. So it's pretty simple, and I just hope you get a little something out of it. With that being said, first thing I want to really everybody to remember is that people with disabilities are just like us. Intellectual disabilities, developmental disabilities, they're still people. They start out the same as all of us. They have good days and bad days. They have fears. A lot of times they have a lot more fears than we do because of their disability. They don't understand what's going on, but they're the same as our fears. I mean, if you walk into a dental office from their perspective, you probably would have the same fears they have. Likes and dislikes, they're just like us. Everybody has things they like. You have a patient that you're having a particular difficult time with, and they're developing disabled, and you think, well, if I just did it, maybe they just don't like you, and you're the only choice of dentist they have. And that's sometimes hard, but a lot of times they can't just pick the next dentist down the road because he or she walked in the room better the first time. So they definitely can develop their own personal likes, just like everybody else. So I try and keep that in the forefront of when I'm working. It's not always due to their disability, the way they interact. So moving on to intellectual disability. So this is a wide-ranging, and a lot of times it gets thrown in with developmental disabilities, but not all intellectual disabilities are developmental. Some of them are due to traumatic incidents. A lot of times as a child, somebody gets in a car wreck that could affect their their intellectual abilities. There's also, if they have problems with birth, and they're going to be a little different than some of your genetic developmental. And I'm starting here because it kind of provides the basis of some of the challenges and barriers are going to be a little different based on the history, the reason why the person is disabled. So specifically talking about developmental disabilities, is I find that how functional they are a lot of times can tell you a lot about how severe their brain abnormality is. And that's important with these 2 points down here at the bottom. So the brain abnormality, so where the disability is in their brain, because the brain controls everything in the human body, can affect different organ systems. But also at the same time, when they were developing, when their brain was developing, their other organs were developing. So if there was this possible genetic problem going on during that development, there could have been a genetic in another organ. So why is that important? Well, sometimes one of the big barriers is they may not react the same physiologically, and that could be due to, well, maybe their liver doesn't work as well because some part of their brain isn't telling it to work as well, or it could be their liver doesn't work as well because it has also a disability inside of it as well. So, and that can be a barrier and a challenge. Here I have pretty good historical background on my patients. I don't know you always get that out there, in the community. My patients a lot of times lived in the system from a very early age, so we know a lot about them. A lot of research has gone into about why they're disabled, genetic testing. You may have access to that or not. But some disabled people that walk into your practice, you may not know, or they may not know, or their caregiver might not know the exact details, how long their birth mother went, did they go to term or were they premature? Have they had genetic testing and all those things? So you may not know those, but it is helpful to ask. So again, the barrier not knowing is to ask. Ask the caregiver. You know, do you know the nature of the disability? Of course, then there's the common genetic disabilities, Downs, and a lot of times it'll be just, oh, it's Downs, and those type of things. So exactly what type of intellectual disability can be the first challenge. I'll move. I talked a lot about airway in my last presentation. I'm going to bring it up here again because I think it's so important with patients with disabilities, especially intellectual disabilities, because the swallow is such a complex activity. And I kind of akin it to fine motor skills, because I see two things with or commonalities among a lot of the people I worked with when I started working here, is almost none of them knit, and almost all of them have some problem with the swallow. Now that's not all people, but again, higher functioning is, you'll find more, if they talk, especially if they make meaningful talk, they probably have a little bit better swallow, but not always, because speaking is a high function, but also swallowing is. So I think we all forget about how complex the human swallow is, the muscle coordination and all that. So now, what are the, so that's the barrier is poor airway. Well, the fix is evaluating that airway. It's being extra careful with patients with lower function, especially if you know they have a swallow problem. How you're going to know that is if they're on a modified diet, if they have a tracheostomy, if they have a G-tube, there are a lot of those indicators. One way you might build it is by asking the caregiver what they eat. So patients that don't eat solid foods, they have to cut them, or they tend to choke on them, probably have an impaired swallow. Now, not always. Sometimes they're having their food cut because they don't have the manual dexterity to cut themselves, or they have a physical disability that doesn't allow them to cut their food. So you kind of asking some. But if you establish that they have a compromised airway, the fix is, how are you going to protect that airway? And I hope I'm not talking down to this too much, but I don't feel like I got a lot of airway management training in dental school. Mostly it came in my military days after. And it wasn't even part of my dental training. It was more part of my trauma training with other courses. So, but in dentistry, as far as I've researched, we actually do a lot with high volume suction and an assistant. We work with the airway every day. I don't want to say we don't. I think sometimes we just kind of lose our respect for it, because yes, we're working around our airway all the time. We're working with small objects, and we know don't drop them down the throat. That's good. Our assistants are trained to manage fluids. So all that training is the same training that you need to protect the airway in a patient with IDD. It's just being more cognizant of it. Like, I'm not suctioning this patient out so that because it's more comfortable for them, or I don't want them to cough, which you don't, but I'm also protecting their airway. And I think that's what I didn't really think about when I first started this, or when I was in dental school, is, we hung the suction in the mouth so we wouldn't have to stop as often, and so we could get more dentistry done. I never thought of it as protecting the airway. And then this slide is from my anesthesia lecture. So it's also talking about when you're doing anesthesia, stopping a second for a patient with a developmental or intellectual disability and thinking about what kind of airway you should use. Should I do this case open? Meaning just suction, no airway. Should I take this patient to the hospital or get an anesthesiologist or myself to intubate this patient? What is their ability to cough things back up? And the LMA, again, is the laryngeal mask airway. That's kind of a middle ground between fully intubated and fully open. So much more on that on my other record. And then I'll say this again, because I always say it, not just for patients with intellectual disability, but for all sedated patients, please consider your airway at least partially compromised. Rubber dam, chair placement for a sedated patient, especially if they're snoring, then you've got an occluded airway. So that's just my public service announcement. So next barrier is communication. I'm going to go into this a lot because, and I'm going to get into in just a second, but it's very big communication that we take a lot of for granted with working with neurotypical patients. So communication, I start with verbal versus nonverbal. That's the biggest part. Obviously, if a patient can talk to you, you get a lot more than if they can't talk to you. And yes, even patients that can't speak who have disabilities can communicate. There's sign language, they can do a lot, but almost always in dentistry, that communication is going to be compromised. Even if your sign language is perfect, and their sign language is perfect, which realistically, a lot of times their sign language, if they have an intellectual disability, I'm not talking about a person who's just mute, but if they have IQ issues, they have, learning sign language is just like learning a language. They may not have a full grasp of that language, even though they do use sign. And then again, even sign language, in dentistry, you don't have the full vocabulary. I've never seen somebody try and sign, dental drill, but there might be a sign for that. I'm not a sign language expert by any stretch of the imagination. But then that moves on to the next one, is ability to understand. So you take somebody with an intellectual disability, they may talk pretty clear to you, but how much are they understanding? And I even always, before I worked here in private practice, I often ask myself how much of my patients were really understanding what I was talking about. There's a lot of funny videos about what patients really hear at the dental office. But when you take a person with intellectual disability, you do have to take it with a grain of salt of what they're communicating to you, even if they can speak, because they may have a very different idea of what pain is, those kind of things. So I do encourage you to realistically assess their ability to understand. A caregiver may say, "Oh no, they understand perfectly fine," but you do need to realistically assess how much they understand. Of course, in my job, unfortunately, most of my patients have very little ability to understand, and it does affect treatment. And we're going to talk a little more about that. And then lastly, but with a patient that can communicate verbally, if they have mental health issues, remember, people with intellectual and developmental disability are not just their one disability they wear every day. They can have other comorbidities. In fact, they usually do. So a person with mild IDD may still have very significant anxiety due to past trauma. And even though they're communicating verbally with you, they are filtering your communication through anxiety. And that may change what they hear. So that's the barrier. What do we do? What's the pearl? Slowing down. I know that's hard in private practice, but do they really understand what's going on? And I know that's simply said, but luckily I work in a government institution, so slowing down is an option. I know that can be much more difficult. The next is I like to put myself in their place. What would I hear if I were them? And I guess that's that empathizing character. You have to be careful with that because you're putting yourself on somebody else's shoes, but I think we do have to. So where I found communication to be the biggest barrier when I started working at this facility was with diagnostics. I suddenly realized that almost all diagnostic and diagnosis in dentistry is verbal based. We have very few truly objective numbers that, even like pulp testing. So you take some endo ice and you put it on a tooth. Well, you do that to a patient that doesn't understand what you're doing. Even if you tell them, tell, show, do, you tell them what you're doing, then they have limited ability to understand it. What does it even mean if they raise their hand? Did that hurt? Oh, that hurt. Does that really mean what it means with a neurotypical patient where you're pretty sure they know what you mean? Even in EPT with numbers, I mean, you still got to have them raise their hand, right? Or that's what we learned at San Antonio was, raise your hand when you feel something. Patients with intellectual disabilities might be raising hand just because they like raising, they think you want to give them a high five. So the other part is, I was told in dental school, I think everybody was, it's an old cliche thing is, listen to a patient long enough, they'll tell you what's wrong with them. That doesn't always work with patients with intellectual disabilities, especially, they can't talk, they can't tell you what's wrong with them. They have limited understanding of what's wrong with them. They may know their body parts in a general fashion, this is a head, but, your head hurting versus your tooth hurting in a patient with intellectual disability, especially a pretty low functioning one, that may get jumbled up, and you end up with root canals everywhere when really they were just having a headache. And it doesn't have really to do with communication, but x-rays, not as easily obtained with patients with this population. So one of the barriers is, you may not have all the diagnostics because you don't have the verbal input. You may not have a great x-ray, and it's still trying to treat them the best and ethically as you can. Sometimes you end up doing a root canal because you think you needed to. You find a vital pulp. I don't do root canals, so it doesn't happen very often. So that's the barrier. What's the, how do you overcome it? Again, take your time, try and be methodical, and do you use what you can. I do a lot of observation. I do a lot of palpation because you still can. If somebody's having a toothache and you push on that tooth, did it hurt? Did it not hurt? So it's kind of going back to a lot of the basics of diagnosis. Eating, sleeping, pooping, peeing, doctor, I think this person is having a toothache. The caregiver a lot of times say this. Well, why are they having a toothache? Well, they're beating up their caregiver, and they did that one time when their tooth hurt them. Okay, that's fine. Are they pushing on their tooth or anything? Well, they kind of hit themselves in the side of the face. Okay. Well, are they sleeping all night? Because we all know that nocturnal pain is a sign of pulpal necrosis. Yeah, no, they're not having any problems sleeping. Okay, are they eating normally? Oh yeah, they eat. They haven't missed a single meal. Okay, well, maybe it's their tooth, but maybe it's not. But even then, you got a patient with 3 seizure medications, they may be able to eat quite a bit, even when they don't. They may have altered pain inputs. So again, slowing down, taking your time, really thinking about it is the answer to that. Getting what diagnostics you can. An x-ray is very useful if you can get it. And that leads me in my next part, which is a barrier that kind of precedes the next one, is acute versus chronic condition. Again, I took this slide from my last, but I wanted to trigger that the types of disease process you're going to see in patients with intellectual disabilities tend to be more progressed. I believe that is not just due to their access to care, which they do have access and barriers to care, but it is also because of that diagnostic communication problem. Endodontics, we very rarely see early stage pulpitis. cold sensitivity here. Patients with intellectual disability, again, depending on their disability level, you know, they're not going to notice, like I said, especially if they're on multiple medications for mental health problems and seizures, they're not going to notice cold sensitivity. So you're not seeing a tooth till it has a chronic abscess. And that does affect your treatment. You know, we all know that a root canal on an abscess tooth, especially when you don't even know how long that abscess has been there, you know, you can expect less success with those. It's still good numbers. Don't stop doing root canals just because it's got an abscess. But caries, you know, especially if they don't have a lot of cooperation, you know, you might see a lot bigger caries. Periodontal disease is very difficult to treat in this population. Again, cooperation, home motivation, all those things. So be prepared to treat things in a little more advanced cases. You know, if you're a dentist that really only likes doing small conservative fillings, you know, everything else is a crown, expect to be doing a lot of crowns. We don't get as good at x-ray even on people we can get x-rayed. Finding small caries is difficult. So I got a question here. Is biting oneself a sign of dental issues? That's a good question. Unfortunately, we call that SIB here, self-injurious behavior. It's an all-encompassing thing. Biting yourself, hitting yourself. A lot of times it's a communication. You know, especially in a nonverbal patient, they may have learned long ago that when they bite themselves, they get attention. And why do they want that attention? Yes, it could be a sign that they're having a toothache, but it could also be a sign that they have a headache. It could be also a sensory seeking behavior. So 10 to 15 showers a day is probably some OCD. Again, remember, disabled people a lot of times come with a lot of mental health issues. Obsessive compulsive behavior is common in this patient population. So, but again, obsessive compulsiveness goes up with anxiety as well as pain, and it's all a process. So I think I finished everything on that slide. Moving on to another big barrier that's very common with IDD patients with IDD, is their amount of function. And I'm going to go into this in a little bit more detail. It's not always so simple as whether they're in a wheelchair or they walk, although that is very important. It does, their level of function, though, oftentimes does tell you to some degree of the severity of their intellectual disability or their developmental disability. You know, typically I find that patients that can't walk, they can't talk, they have the more severe problems, and of course that affects their, and we're going to get into this. So that's the problem is, or the barrier is, you know, they have altered ambulation, or they're in a wheelchair, they have no ambulation. So what do you need? You know, you need, well, this isn't just for function, but also for their communication. You need advanced behavior management. In dental school, you know, basically any behavior management was advanced and left to the pedodontists. You know, but you're going to need tell, show, do, calm voice. I don't call those advanced, we call that pretty standard around here. But again, sedation can help. Special equipment, especially with the function. They do make wheelchair lifts. I've never actually used one. We don't have one, believe it or not. They're very large. They're very expensive from what I understand. I also get concerned, you know, yeah, putting a patient in a more desirable position can be good, but it can also not be good. You got to watch how much you tilt them. And I know the wheelchair lifts, you know, go up and down. I don't know if they go back and forth. But you know, those can, if you find they help with the practice, you know, I do encourage you use whatever tools you can, as long as it's done safely. Special equipment though that I would tell you I would strongly recommend looking at, and it's not really special equipment, it's just watch your dental office. People with wheelchairs are going to need wider doors. How are they going to get into your operatory? You know, and I'm not saying change around your whole office, but especially if you are expecting to build an office and you do want to treat patients with IDD, spring for the little bit bigger openings. You know, I know everything's supposed to be ADA compliant, but as far as I know, ADA doesn't actually extend all the way into the dental operatory, or at least it doesn't look like it sometimes. You know, where are you going to put the cabinet? You know, I know dental operatories are priced per square millimeter, so you know, going bigger is not all is more expensive. But you may really appreciate that when you're trying to transfer somebody from a wheelchair to a dental chair. And then I threw down the special training. I'd love everybody to have come spend some time with me. You're welcome to. You know, there is a lot of special training. It's a lot like treating regular people and just figuring it out. So I don't think you need any special training to treat patients with IDD. You really need to just have a heart for it and do the best you can. And I'm moving along because, again, I find myself falling behind here. I apologize. So ambulation in wheelchairs, I brought this slide back in a little bit. There's very many levels of ambulation. And so you have completely wheelchair dependent, and then you have people that walk and they've never been in a wheelchair. But then you have a lot of shades of gray in between. That can be a barrier because are you going to transfer this person to a dental chair? Do they normally do transfer? They may sleep in a bed. I would be asking how complicated it is to get them in bed. You ask your caregiver, you know, what's your bedtime routine? Well, it's 3 hours of slow movement. That's a gross example, but you know, if it takes a long time to get them into bed, it's going to take a long time to get them into your dental chair safely. What kind of wheelchair do they have? Is it safe to do? You know, does it have a headrest? A lot of them do, especially at our facility. You know, so you have some head stabilization. But if they have a wheelchair that got secondhand and there's really no support, maybe it's worth a little more risk to transfer them to the dental chair. But some of them, it's going to be super easy. Yeah, they only really use the wheelchair part of the time. And in fact, they usually ambulate at home. Okay, well, they're going to be able to stand and pivot, maybe with a little assistance. But, you know, that's the how to overcome that barrier is just ask them, you know, how are they at home? Do they get in and out of their wheelchair a lot? Or are they pretty much 100% dependent on it, except bedtime? You know, they get out once at night and they get back in it in the morning. You know, that's going to help you with where you're going to be doing your care. Again, coming back to case considerations, bringing back here's what I learned to ask myself, and I take these into consideration. I love the ASA classification. I really started using it here a whole lot more than I really used it, you know, in private practice, especially in the military. Everybody's ASA 2. You can't be in the military, with rare exceptions, and be an ASA 3. It is good. I think you do have to adapt it a little bit to patients with disabilities, because ASA 3, severe systemic disease that limits activity. Well, all of my patients that live out here have limited activity. That's why they live here. But I don't think they're all ASA 3. But you could consider them that. I often ask myself, you know, a person running around with a G tube, even though they may literally be running around, are they an ASA 3 just because they have a G tube? You probably won't see as much of that out and around as I do, but you might, and you have to ask yourself that question. By the way, I do consider G tubes to be ASA 3 at least, if not more. So these are kind of the questions I ask myself, and hopefully this is helping you overcome some of those barriers is these case considerations. So this is a slide from my last one. I really just put in here to is to kind of carefully consider each step along the way. Another way is asking yourself where the best place to treat a patient. And I'm not just talking about doing a cleaning or something, but even simple fillings on a very disabled person can be complicated. Something you could do on a neurotypical person right after they're cleaning, you found another cavity and do it. That may not be possible, not due to the nature of the dentistry, but due to the nature of the patient. So, and not that hospitals have any special, they do have special equipment, but they also are, if you do run into a complication, you're already in the right place. That's kind of the mentality. There are cases where I don't think the hospital is the safest place for patients, especially with our recent pandemic issues. I had to ask myself, is the hospital the safest place? But I will tell you, culturally, in dentistry and medicine, if you do have a complication, you always have to be aware that somebody may ask you, doctor, why was this being done in your office and not in a hospital on this particular patient? So, I know a lot of dentists don't have hospital privileges, but it is a very useful thing. I think it's something we need to bring more into our profession. I know it's not easy. Hospitals are hard to work with. I don't even like going to the hospital, but it is something to look into it if you have that available, because you may need it. This slide again, I reused. I'm trying to say slowing down and taking your time is more important with patients with IDT, because a lot of these things that we were taught in dental school were actually meant for patients with IDD and not so much meant for the patient we were going to see. I just didn't realize it at the time. Good medical history. And in this preoperative, I'm talking more about with anesthesia. A lot of your patients, you're not going to get lab work on almost. I mean, when in dental school, did you ask for lab work? Patients are generally healthy, ASA2. You don't really need lab work. Do you need to consult a physician? We were taught in dental school to consult physicians. When you start working with patients with IDD, I think you really need to look at your preoperative evaluation, whether you're using anesthesia or not, and ask yourself what you need as the surgeon. Because remember, in classic medicine, you are the surgeon. You're actually responsible, the person responsible, especially because you're providing the care. And don't hesitate to ask. I mean, if you feel like you need a chest X-ray, a person in a wheelchair with a whole lot of scoliosis, you may want to know how much. Now, not that you need to read that, but you may want to know they have a clear field. Now, I know that's a lot easier for me. I work in an institution where I can order tests. Actually, I don't order the test, but I have a PCP across the hall. I can knock on his door, and he'll order the test for me. And we do a full blanket of tests prior to anesthesia. Not saying you need that in every case. My anesthesiologist is often like, well, you don't need all that, but we have it, so we use it a lot. But I have learned that they are valuable. If you're going to be taking a lot of teeth, a bleeding test can be useful. Now, are you going to order that? Probably not, but the person's physician can. And so that goes back to when you work with patients with IDD, having a good relationship or trying to learn to speak with our medical colleagues, I really think is a great skill to be learned. And I know it's harder out in where y'all work. Y'all don't have them right across the hallway and talk to them every day. And I know they're busy and that can be difficult. So I saw a question pop up here. Oh, that's a difficult question. The question is, how does one get hospital or OR access with staffing shortages? Hospitals vary a lot from place to place. And you may not be successful just based on the hospital. But again, you may be successful as a dentist. A good place to start, every hospital I've ever worked in, that's not a ton, but everywhere I've ever seen, there's some sort of credentialing office. And there is going to be a credentialing process at every hospital. And it's just finding out what that credentialing process is. Do you meet it? But also that credentialing office, if you can get them on the phone, some are easier than others. Are there any dentists currently on staff? it might be good to call up if there is an old dentist on staff. He may not even be working much at the hospital anymore, but it might be good to introduce yourself, see how he got in. So I hope that helps. Yeah, prioritizing OR care. My hospital had a dental day already for the pedodontist. It wasn't heavily utilized. So there is a dental day. Don't always assume that we're low on the totem pole, especially with patients with IDD. I was all prepared to actually even go to the hospital. Thankfully, I didn't have to go to the medical director or the board and talk about disabled people and not allowing care. The care you're providing is important. Don't let them tell you it's not. Yes, I understand this patient doesn't get a heart transplant, they're going to die. Are we that important? No, but are we more important than the breast implants getting put in down the hall? Now be careful with that. Overstep yourself as a dentist. You don't make many friends, but I got to move on or I'm going to run out of time. But yeah, hospitals are a crazy thing to get into. Don't have to do it alone. I plug anesthesiologists. Find yourself an anesthesiologist, especially a dental one. This is my plug for my dental anesthesiologist. That's been the greatest thing I've learned to work with here. It helps you overcome so much. They're great references, but even a medical anesthesiologist can be very helpful. And I'm going to have to speed up here again because I got talking too much yet again. I'm going to talk a lot more about this, and this is what my half of my next presentation is over, so I'm not getting into it. Just from this slide, no, your patients are not going to be like your other patients usually. If they're living at home, are they living in a group home? Are they living in an institution like this? That does affect care, because they got to get a ride, you know. So again, we're going to go into this a lot more in my next, as well as the government funding. Sorry, I don't get into that too much, but you know, their type of funding. So one of the barriers is if you want to work with patients with IDD, unless you're going to do it all pro bono, you're probably going to have to learn how to interact with government funding, Medicare, Medicaid. Bless you. I know it's not easy. Thankfully, I don't have to do that. It's all handled by my facility. I don't have a good answer for that. It's not pleasant. It's not fun. Write your congressman. Sorry, bad joke. I apologize. I wanted to get into this a little bit, and I'm kind of running low on time. Uncommon comorbidities that I ran into working here. Oh, actually, sorry, I was going to bring up big one, aspiration pneumonia. Did not learn anything about pneumonia in dental school, despite the fact that it is probably the #1 killer of patients with IDD as well as older patients. And I don't remember getting a single lecture on it. Maybe I was asleep that day. I hope I wasn't. I've asked several dentists. They didn't do it. But other conditions you'll see in this population, I don't think you'll see in a lot of neurotypical populations, is poor eating. You know, eating is very important to people. It's important to patients with IDD. But in a neurotypical patient, they'll usually come running when they can't eat right. In ours, with all their barriers to access and things, they may not have that voice. So a big one I learned was failure to thrive. Unless you work in geriatrics or very young pediatrics, I don't think you see a lot of failure to thrive, but you may see it with patients with IDD. They have a lot of comorbidities, all of which may be fairly significant. They may not be in any, no one of them may be severe, but when you mix them all together, it may make a condition where they are just not thriving. You know, you go to fix one problem and that makes the other one worse, and you end up in this rock and a hard place. So failure to thrive can be a thing. Commonly uncommon conditions, that was my joke. Things I ran into here with see on a daily basis that never, seizures. Intellectual disability, developmental disability, a lot of times comes with seizures, a seizure disorder, a patient with 1, 2, 3 seizure medications, VNS, that's a vagal nerve stimulator. By the way, if they have a VNS, that means they have really bad seizures, because that doesn't fix seizures. That's kind of like their last ditch effort to try and help them out. They are useful, but they're not 100%. Constipation and obstruction. I never really thought about the other end of the tube, especially in dental school. But when you get working with patients with IDD, poop becomes very important. It's not just their developmental disability. They're usually on a lot of medications, anticholinergic effects come into play. And this is more for anesthesia. I learned to really value poop with anesthesia because we all know that one of the, I want to call it a common post-anesthesia complication is constipation, especially if you're using a lot of narcotics. So you got somebody who already has a lot of problems with constipation. Maybe we want to stay away from so many of the narcotics. And I don't personally give the narcotics, but you need to kind of know when you're talking to your anesthesiologist, okay, this person takes 4 medications for constipation, still has an order for a suppository or still needs a suppository every once in a while. Hey, can you hold off on the fentanyl a little bit? Can we, do some more gas versus some of that? And not that the answer will always be yes, but having some answers for it. History of pneumonia. I want to caveat, a lot of patients with IDD had pneumonia issues when they were small children or babies. I mean, if they're now 45 and they hadn't had pneumonia in 3 decades, it's probably not a problem. But if you ask the caregiver, did they ever have any problems with pneumonia? Oh yeah, they were in the hospital last week. This person has a compromised respiratory system. They've been in the hospital 4 times the last year. They have a super compromised airway. You want to be very careful. They may also have some problems. And I'm getting here. So I'll move on. Thank you, Ms. Beth. Again, back to this slide, I went over very good in detail last time. Again, I didn't use a whole lot. These guidelines don't specifically, I just throw them up because they're kind of the parts that I read that I found useful. Hopefully you can screenshot this if you're really interested in reading this one. I really like that AAPD was a real good one. This study down here at the bottom I found very useful because it showed what a lot of people are using anesthesia for, and it's not really guidelines, but I feel like, oh yeah, most of the people are using them for this reason. I felt better about this. So I'll finish with one last slide. Comprehensive care for all. Yes, I wish everybody with IDD, but I do want to always finish my lecture with, do what's realistic, but do more than just the basic if you can. Do they deserve implants, bridges, and aesthetics? Yes, they do. Do they always need it? No, they may not. If they're on a pureed diet, do they really need full mouth rehab? Do they understand? Dentures are my big one. Yes, dentures are great, but think of it from a person who can't understand what you're doing. It's just a big old piece of plastic in their mouth they didn't want in the first place. So you may find more of that. So please don't say they don't need that because they're disabled, but also don't overtreat. So that's kind of my final message. And that's where I finish up. So I had to again rush. I guess I'll cut it down a few more slides next time. Here's my last bit of my contact information. I love talking to anybody, probably more than people like hearing me talk. I love hearing you guys too. I really do. Please, I love talking about this stuff, and there's not a lot of people to talk to. That's all I have, Miss Beth. If anybody has any more questions or.
I do believe we do have some questions, Dr. Bullock, and thank you for your presentation. I'm sorry, I didn't mean to rush you too much, but
you do not. You need to do that, Miss Beth. Please don't be sorry.
I did want to let some of our attendees ask some questions. I noticed Elizabeth Stanford. Elizabeth, if you're still on, we can unmute you. You put a question in the chat box, and then I saw a follow-up in the Q&A. I just want to make sure he has the opportunity to address your question. So let us unmute you, and you can ask live.
Can y'all hear me?
I'm sorry, I can't. I really can't hear.
We're not able to hear you. Well, I can read it for her. And you talked a little bit about it in your presentation. She asked, do you have any suggestions on how Medicaid dental providers can get a hospital to take the patients that need to be sedated to do dental work? The hospital in Amarillo Northwest has turned away patients after they had already approved for the patient to get services done at the hospital. This hospital is not wanting to take Medicaid patients due to reimbursement rate and the time it takes for the surgery.
Yeah, I really don't. Like I said, I don't deal directly with Medicaid, and that's and even though I don't deal directly with them, I do. It is a frustrating part because it is the primary funding mechanism for patients with disabilities. It was designed for pediatric patients. Medicaid itself, as I understand, was designed for pediatric patients, and then they kind of just tacked on disabled people, and they wonder why it doesn't work very well. That's probably why. I don't really have a lot of suggestions. From my experience, hospitals are about relationship. I mean, of course, if you have another hospital to work with, that's always great. But in a lot of places in Texas, there aren't just bunches of hospitals. If you can try and get a hold of the hospital director or the medical director, but go into it as a conversation. You know, I wouldn't go running in, you know, as the dentist into a hospital. You know, it's kind of more just trying, hey, can I set up a meeting with that person? I've got this case, and also keep it case specific. I have this case, little Johnny. That'd be the only thing I'd have to help you out. And don't try and fix the system. Try and help your case, and then work on the next case. I hope that.
Yeah, this is Elizabeth.
Yeah.
It does help, and you know, we've done that. I work for Texas Health Steps, the Medicaid program for children. So, boy, I understand Medicaid is not easy, even though it's who I work for. But man, we're just. Plus, I used to be a special ed teacher, so our poor kiddos are just in pain, and they've gone up to the hospital and were turned away after everything had been approved. And so, you know, they're just not wanting to do it because of the reimbursement rate. I mean, it's a great hospital, don't get me wrong, but I don't, yeah, we're just still working. So if anybody out there has any other suggestions, please let me know. But I do like the specific things that you said about going into this conversation in case specific. So we'll go back to them and try again.
Again, and there may even be an ethics committee.
Mm-hmm.
Yeah, sometimes it's just not asking the right way at hospitals. And we do that as dentists a lot because we weren't trained in hospitals. It's not just that. As dentists, we're not even trained the right lingo. You know, they use weird words that we don't use. And in medicine, I find that makes people uncomfortable. So if you can even find a physician that can maybe help you, not a physician that works with Medicaid as well, maybe could help out because he's sort of a liaison, or a nurse that talks right, moves right. I don't know if that helps.
Yeah, we're working on it. Our regional medical director is helping out, and you know, he knows the director of the hospital. But I like the way you presented that. Thank you.
You're welcome.
Elizabeth, this is Beth again.
Yeah.
I'll also reach out to some dentists that I do know that have some hospital privileges up in the Dallas North Texas area.
Yeah.
And find out what they did and see if I can find out any information for you and kind of connect you with them if possible. Okay.
Okay. Thank you, Beth. I appreciate it.
You're welcome. Thank you so much for attending today. Dr. Harani, I see that a question up here that you had something about apnea. Would you like to, we can unmute you where you can ask your question verbally. Are you able to ask your question, Dr. Harani?
Yes, hello. Can you guys hear me?
Yes,
I can hear you, yes.
Yes.
Perfect. Well, great presentation, Dr. Bullock. And I'm so sorry I missed your first one, but you talked about compromised airway. Do you recommend doing sleep apnea screenings for IDD members? And do you believe oral appliance therapy would help if they can tolerate it? You know, with the sleep apnea weight gain, we have several members that are over 300 pounds, 15-year-olds. And so I was wondering if that's a recommendation with sleep apnea.
Good question. Thank you for that. Yes, if you can do, I don't screen for sleep apnea because, like I said, I work in an institution where their PCPs do that. A lot of our patients do have sleep apnea. We have patients that sleep with CPAPs. Again, intellectual disability is very difficult because making one blanket statement is, you have to take each case like itself and the barriers to it. So yes, I do recommend we diagnose all we can. I would strongly encourage you to be in relationship with a physician or a
PCP,
pulmonologist,
yep.
somebody on the
Sleep
medical side of health if you are doing sleep apnea screenings, because great, you're doing the screening, maybe you're getting the bill, some insurance for it, but where do they go after that? Because I can tell you, we can't handle that all in dentistry. Now, I also know that's hard because I've recently had a problem here. We had a patient, he had a hard time getting the home, he had a hard time with the sleep study because he was intellectually disabled, but he has Downs and a heart condition. He doesn't need to have sleep apnea. So his PCP got him approved through a respiratory therapist doing a home study. There are home studies which people tolerate better, but of course the pulmonologist is a little bit older and, well, yeah, I can do that, and there's a lot of back and forth. And then I threw up my hand and said, what about an oral appliance? One downside with oral appliances for sleep apnea that I see is they're removable.
Right.
Be very careful with removable, because remember, one contraindication to removable dental appliances, prostheses, or appliances is intellectual disability. The only patient that can swallow a full arch appliance is a patient with intellectual disability. I mean, we were shown the person who had the denture, full arch denture in their throat. So you always be careful with that. Doesn't mean no, but do be assessing and do be getting good consent. I think this might help because oral appliances I really do believe help with sleep apnea. I know everybody says the CPAP is the gold standard.
Yeah.
Yeah, but I always like to ask that person, have you ever slept with one? I haven't, but from what I understand, it's like sleeping with the blow dryer on your face.
Yeah.
They're not well tolerated. Oral appliances are generally better tolerated. I also recently had a discussion with somebody. They were talking about a study that was showing, and a third party I know, but they're showing that there's, like with any medication combo therapy, there's a lot to combo therapy. Now, my theory is because almost all apnea cases are a combination of central and peripheral. That's why you get a little, so
Right.
Did that answer your question?
It did very well, and you also answered my biting question and the hospital question very well. We have the same issue.
The last part about that, sorry, is then once you decide this, yes, you've screened this case, yes, they might be good for an appliance. Now you got to ask yourself how you're going to get those impressions.
Right.
I don't have a lot of experience with digital impressions, but one of my consultants with that particular case was talking about making the oral appliance using a digital impression. Introducing goo into a compromised airway is not fun. Especially if you're talking IV sedation or just light sedation with an open airway. Be careful with whatever goo, but you take away a lot of that with a digital scan.
Yeah, digital scans work very well. They work very well. I have experience with them, and but you're absolutely
right. But on an
right.
awake patient, somebody with epilepsy or cerebral palsy, they ain't going to be able to hold still for that. You may be talking about intubation and a class, and then using your scanner or your impression material. So,
great, thank you.
You're welcome.
Thank you very much. Great presentation.
All right. Well, thank you again, Dr. Bullock. I believe our time is up today. And if he didn't get a chance to respond to any questions, or if you have any follow-up questions and didn't get his contact information down, just email me down here at info@texsoc.org, and I can send you his contact information. But thank you again for your presentation today. Thank you, attendees, for joining us. So thank you again for attending, and we hope you enjoy the rest of your afternoon and have a nice weekend.